So today we will discuss about the chelating agents in heavy metal poisoning. So what are these chelating agents? Chelate, what do you mean by chelate? So chelating means it is a term used in chemistry. So what happens? Heavy metal poisoning. Heavy metal means arsenic, bismuth, antimony, gold, cadmium. These are all heavy metals. Mercury, lead. So heavy metal poisoning is quite common in all of the world as well as in our country, mainly due to the environmental pollution. So pollution happens, and due to the pollution, heavy metals are quite rich in the river and different types of the water reservoirs. And through this, heavy metal poisoning happens. Mostly these are the chronic heavy metal poisoning. And there is, of course, there are some instances of acute heavy metal poisoning when some high doses of the lead or mercury or some other came into the body of one individual. So heavy metals poisoning when happens, what are the problems? So problems are when a heavy metal is taken, these heavy metals basically attaches with some ligands, different types of the ligands that are important component of our normal biological enzymes. For example, sulfhydryl group. You know the SH group, sulfhydryl group is quite important in different types of the biological enzymes. So when a heavy metal is given in high dose or present in our body, that can attaches with the sulfhydryl group, for example, and depletes this. When the depletion of these important biological groups or ligands happen, ultimately that leads to interruption in different normal biological processes, normal enzymatic processes, normal homeostasis, physiological metabolism. Similar thing happens with the oxidized, different types of the hydroxyl group, different other groups. So when these heavy metals are present in our body in high doses, that depletes the different important ligands which are component of different biological enzymes. Most common example is the sulfhydryl group. So depletion of this sulfhydryl group or hydroxyl group or other groups happen when there is very high heavy metals in our body. For example, you can see that in different water reservoirs in our states also, their water is very much arsenic rich. So arsenic is very high, it's present in the water. When this is present in the very high and this water is consumed, that arsenic attaches with these different ligands, and ultimately these enzymes, which are important components of different physiological metabolism pathway, that are interrupted. So that is the problem. Similar thing happens in lead poisoning also, mercury poisoning, lead poisoning. These are quite common, and mainly this happens due to the increased pollution. You can see there are different industrial remains or industrial matters are usually flowed into the river, and this ultimately pollutes the river, and when the water is taken from this river, water is consumed from it, even if it is filtered or it is done some refining, this heavy metal concentration will not become very less. So heavy metal concentration should be in a stipulated range, but in most of our water reservoir contains very high amount of heavy metals. This leads to the heavy metal poisoning. So what does this chelating agents mainly causes? So when these heavy metals are high, already we have seen that they are depleting the important ligands. When these chelating agents are given, they are attached with these heavy metals so that the normal ligands that will be depleted will be left away. So this chelating agents itself competes with these ligands of important biological enzymes and attaches with these heavy metals just like a crab. Chelates means a crab, okay. Just like a crab, it attaches with the heavy metals and chelates this. Chelates means it is attaches with the heavy metal, and this heavy metal chelating agent complex becomes less poisonous to our body, that becomes more hydrophilic, and that are usually excreted through the urine or other stools or etc. So that our body, the different enzyme system, different cells of our body will be harmless. So that is the motto of the chelating agent, that is the usage of the chelating agent. So it is clear? So the same thing, Same thing what I am talking. So Greek, this is a Greek word chelin, means crab. They mainly attaches with this and forms a ring-like structure. So they form stable, non-toxic and easily excreted complexes with toxic metals, and they are valuable in heavy metal poisoning. And this heavy metal poisoning becomes more common in our country also with more and more pollution. So basically they contain two or more reactive group or ligands, and this attaches with the heavy metals and ultimately they causes a ring-like structure and it is stable. This ligand is a functional group capable of forming coordinate bond. So basically this is a basic of the coordinate chemistry. You have read chemistry in the 11-12, this is a part of the coordinate chemistry. So they form the coordinate bond, and generally oxygen, nitrogen or sulfur atoms in the hydroxyl, carboxyl, keto, sulfidyl, disulfide, amino or phosphate groups. These groups are mainly affected, and these groups containing enzymes are important in different biological pathways and different physiological pathways. These heavy metals exert their toxic effects by combining with or inactivating these functional groups, what I have already explained. These chelating agents compete with these body ligands. So these chelating agents compete with these ligands, this sulfidyl group, hydroxyl group, etc., and they itself attaches with the heavy metals so that these important groups will be left away. They will not be harmed. Like now they differ in their affinity for different metals. So different chelating agents have different affinity to different metals, and accordingly in different poisoning, different chelating agents are usually chosen. Usually clinically useful agents should have a higher affinity for the toxic metal. So when these chelating agents are given, the affinity of these chelating agents should be higher than the normal ligand, so that in the competition they will win, like this. And calcium, because normally calcium is normal chelators in our body, so there should be more affinity towards this in comparison to the calcium also. So they should also have higher affinity than the body ligands for the toxic metal, and their distribution in the body should correspond to that of the metal to be chelated, and they should be water soluble. Another thing is, when we are using a chelating agents, usually the dose is given higher so that there will be more free chelating agents present in our body, because not 100% of the heavy metals will be chelated by the chelating agents. Some free heavy metals will always be there. If we are giving more and more chelating agents, and more chelating agents is available in our body, that can chelate more and more heavy metals. So that is the motto. So you can see this is the chelating agent, this is the metallic ion, this is the chelating agent. They are from a crab-like structure, so that a 4 or 5-sided rings are formed. So this is the metallic chelate, and this metallic chelate are usually hydrophilic, and they can be easily excreted through the urine. So these are the important chelating agents. This can be usually asked in the examination, name some chelating agents. So this is the answer: Dimercaprol or British anti-leucite. This is the first chelating agent that was discovered. Dimercaprosuccinic acid, another name is the Succimer. Disodium EDTA, calcium disodium EDTA, Penicillamine, Deferoxamine, Deferoxamine and Deferoxamine. So these are the common chelating agents. Apart from this, there are some other also. They are lesser used. These are the commonly used chelating agents in our armamentarium. Okay. So these are the structures. You can see all these are the structures of different. All these contain different types of the benzene rings. The different types of the free chains that can attaches with the different ligands. So Dimercaprol, Succimer, DMPS, they mainly contains changes in the side chains. So first coming to the Dimercaprol or British anti-leucite, BAL. So what happens during the World War II? It has been seen that different arsenical gases are used in warfare, and this arsenical gas causes arsenic toxicity in the soldiers. So then by means of the invention, it has been seen that Dimercaprol is an agent that can chelate this arsenical gas. Most commonly in the Second World War, one gas is used. This is known as the leucite. Leucite mainly is a arsenical gas. That's why this Dimercaprol is also known as the British anti-leucide, because they are invented by the British against this leucide gas, arsenical gas. There are two sulfidyl groups of this Dimercaprol. These sulfidyl groups of the Dimercaprol bind the heavy metals so that the normal sulfidyl groups in our body that is needed for different biological pathways are left away. They will not be harmed. So they can interact with the other sulfidyl containing enzymes in the body. Due to the heavy metal poisoning like arsenic, mercury, this is gold poisoning, bismuth, nickel, antimony, copper. In different types of the poisoning, this Dimercaprol or British anti-leucide is helpful. The complex of the two molecules of the Dimercaprol with one metal ion is stable than an 1:1 complex. So stability also changes with more and more amount of the drug when it is infused. They form coordination complexes with different side chains. So 2:1 complex becomes more stable, it is seen. So it is desirable to maintain excess of Dimercaprol, what I am telling beforehand. In all of the chelating agents therapy, usually the drug is given in such a way so that the more chelating agents will be available in our body than the normal amount that is needed for the body. So where it is used, usually poisoning by the arsenic. So arsenic poisoning, mercury poisoning, gold poisoning, bismuth poisoning, nickel poisoning and antimony poisoning. So these are the poisoning where the Dimercaprol or British anti-leucide is used. It is administered, usually intramuscular administration is done, 5 mg per kg stat, first it is given, followed by 2 to 3 mg per kg every 4 to 8 hours for 2 days, then once or twice a day for 10 days. It is often used in different biological, different types of the warfare also, and also in different laboratory where sudden poisoning by these compounds happens in different chemistry laboratory. It is partly oxidized and glucuronide conjugated, mainly excreted in 4 to 6 hours. Earlier the treatment is instituted, the better it is. So earlier it is instituted, the more the different enzymes will be left alone. It will form the coordination complexes with these heavy metals and the body will be survived. Because the Dimercaprol metal complex dissociates faster in acidic urine, the released metal can damage the kidney. Hence urine is alkalinized during Dimercaprol therapy. So what happens when this Dimercaprol is given, they form complex, and this complex is usually dissociated more when there is acidic environment. Usually in the kidney or urine there is acidic environment, so there will be more dissociation, and when this dissociation happens, you can see the heavy metals comes out. These heavy metals can block the important ligands in the kidney and the kidney cells will be damaged. That's why urine is usually alkalinized by giving some alkalinizing agent so that there will be less damage to the kidney when the Dimercaprol therapy is done. It is, apart from it is used as an adjuvant to calcium disodium EDTA in lead poisoning. So lead poisoning, it is a second line therapy, but remember Dimercaprol is the first line therapy in this poisoning. Of this, the most common poisoning is the arsenic poisoning. This is the most common poisoning. Apart from this, there may be some gold poisoning, bismuth poisoning, nickel poisoning, antimony poisoning, mercury poisoning, etc. So you can see this is the concentration of the mercury and accordingly different types of the symptoms. So mercury poisoning, when happens at the first, this is the plasma concentration of the mercury in the air as well as in the urine, in urine when the poisoning happens. So first, this is the upper normal range of the urine levels, 5 microgram per liter. So after that, if the mercury concentration in our body increases, that leads to different types of the problems. You can see. So first tremor happens, mercury poisoning. So then different EEG changes, different encephalopathic like characters may happen. Then the decreased verbal intelligence score, nervous system or kidney are involved, neuropathy happens. After that, nervous tissue, kidney, lens of eyes are severely damaged. There may be nephrotic syndrome, gingivitis, pneumonitis can happen, and ultimately in some cases death can also happen. So mercury poisoning, usually this Dimercaprol is used, and this is the you can see from this that with increased concentration of these heavy metals like mercury in our blood, ultimately that leads to damage to the different organ system. Apart from this, it is also used as adjuvant to penicillamine in copper poisoning. Copper poisoning, mainly penicillamine is used. It is used as an adjuvant or second line drug. It is contraindicated in iron and cadmium poisoning. Remember, even if the iron and cadmium are heavy metals, it is contraindicated because when this dimercaprol is used, they form a complex, dimercaprol iron or dimercaprol cadmium. They form a type of complex. This is known as a basket complex. This basket complex is basically more toxic to our body. It has been seen. So where the dimercaprol is contraindicated, it is contraindicated in iron poisoning. It is contraindicated in cadmium poisoning. This is also important for your exam. So apart from this, this is mainly used, dimercaprol is mainly used in other heavy metal poisoning like arsenic poisoning, gold poisoning, bismuth poisoning, nickel poisoning, antimony poisoning. It is used as a second line therapy in copper poisoning, mercury poisoning, etc. etc. Adverse drug reactions. Adverse drug reactions are more usually dose related, distressing, but generally not damaging. Rise in blood pressure, tachycardia, that is increased in heart rate, vomiting, tingling, burning sensation, inflammation of the mucous membrane, sweating, cramps, headache, anxiety can happen. Usually you can see antihistaminics are given. If the antihistaminics are given 30 minutes before this dimercaprol use, usually given intramuscular use, that reduce the intensity of this adverse effect, because all this adverse effect happens due to some form of the anaphylaxis or allergy. So dimercaprol is used in this poisoning, already we have discussed. It is not used in two heavy metal poisoning, iron and cadmium, because they form basket complex that are quite injurious to our body. This dimercaprol, there are some adverse drug reactions, but reactions are less when we are using some antihistaminics 30 minutes before giving the dimercaprol or British anti-Lewicide. Okay? So this is about the dimercaprol. Dimercaprosuccinic acid or Succimer, this is a congener of the dimercaprol. The adverse drug reactions are lesser to it. It is in chelating properties, water soluble, less toxic, orally effective. Its efficacy has been demonstrated in arsenic, mercury and lead poisoning, but it may also chelate some essential metals like copper and zinc. Adverse drug reaction, nausea, anorexia, loose motion can happen. So dimercaprosuccinic acid or Succimer is now more used rather than dimercaprol, because it is just the adverse drug reactions are lesser, otherwise more or less these are similar. Next important, coming to the calcium disodium EDTA. Disodium EDTA is also an chelating agent, but calcium disodium EDTA is more potent. The adverse drug reactions are lesser, more commonly used. It is the calcium chelate of the disodium EDTA. EDTA means EDTA. Okay. They have higher affinity for metals like lead, zinc, cadmium, manganese, copper and some radioactive metals. So it can remove them from the body by exchanging with calcium held by it. So they exchange with calcium and they remove these heavy metals. Highly ionized, distributed only extracellularly, rapidly excreted in urine by glomerular filtration. It is not metabolized in our body. This is not absorbed from the gastrointestinal tract. It does not even enter in the brain or CSF. Thus, it can remove the toxic metals only from the accessible sites. So, lead poisoning, when the brain is affected, it will not be helpful. The calcium disodium EDTA. So, what is calcium disodium EDTA is used? Mainly in case of the lead poisoning. So, you can see this is the pathway how the lead poisoning affects the different systems. Again, the lead poisoning is quite common in children as well as in the adults. You can see with increased concentration there will be changes and ultimately death can also happen here. So what happens? Firstly, there will be increased blood pressure, IQ is decreased, hearing is decreased, growth is decreased, nerve conduction velocity is decreased. So there are different neuropathies happen, systolic blood pressure, diastolic blood pressure changes, encephalopathy, nephropathy, frank anemia happens. Ultimately, encephalopathy can happen and death can also happen when the concentration, you can see 150 nanogram per deciliter. So usually it will be less than this, less than 10. but when it is very high, ultimately death can also happen. So in lead poisoning, the main treatment is the calcium disodium EDTA. Okay, so this can also be asked in the question. So lead poisoning, the main chelating is the calcium disodium EDTA. Most important indication, 1 gram is diluted to 200 or 300 ml of the saline in or glucose solution and infused intravenously over 1 hour. Usually 3 to 5 days is given. Urinary excretion of the lead is promptly increased but declines quickly as the metal is removed from the accessible site. Usually the lead is stored within the bones. So from this it is removed. A second course of this may be repeated after 5 to 7 days. Usually it can also be used in some iron, zinc, copper, manganese and radioactive metal poisoning. So lead poisoning is the #1 indication of the calcium disodium EDTA. Apart from this, it can be also used in iron, zinc, copper, manganese and radioactive metal poisoning. But again, like this, Dimercaprol is not used in iron or cadmium poisoning. Similarly, calcium disodium EDTA is not used, contraindicated in mercury poisoning because mercury is more firmly bound to body constituents and is localized in areas not accessible to calcium disodium EDTA. So for mercury poisoning, we have to use the Dimercaprol or this dimercaprosuccinic acid, Succimer. Calcium disodium EDTA mainly used in lead poisoning or this type of poisoning, but it is not used in mercury poisoning because it is not rich where the mercury is usually stored, mainly in case of the brains, and also the attachment cannot be kept open by this calcium disodium EDTA. So this is important. Already we have seen this. So adverse drug reaction, it does not produce tetany. Usually it is safe. Kidney damage in proximal tubular necrosis may happen. Roughly dose related or problems are. It can be minimized by maintaining high urine flow. So hydration is important. When IV injection of this calcium disodium EDTA is given, usually high doses of the normal saline is also given to maintain the hydration so that the proximal tubular cells of the kidney will not be damaged. Acute febrile reaction with chills, body ache, malaise, tiredness can happen. Again, this happens due to the anaphylaxis. Anaphylactic reactions, fall in blood pressure, congestion, etc. happen. There is also role of the antihistaminics can be given. Next, coming to the penicillamine. This is another important chelating agent. Penicillamine is a dimethylcysteine obtained as a degradation product of the penicillin. Already we have seen penicillin is an antimicrobial agent. From this penicillin, we can obtain the penicillamine. Penicillamine found to have a strong copper chelating property. So the #1 indication of penicillamine is the copper toxicity. Copper toxicity, it selectively chelates the copper, mercury, lead and zinc. So apart from this, it can also be used in mercury, lead and zinc poisoning also. The D isomer is used therapeutically because the L isomer and the racemate produce optic neuritis and more toxic. So there is isomerism in the penicillamine, D penicillamine, L penicillamine. So all the isomers cannot be used because there may be chances of the optic neuritis with the L isomers. It is adequately absorbed after oral administration, little metabolized in the body, excreted in urine and feces, and when given to patients with heavy metal poisoning, excretion of the metal is enhanced. So where this penicillamine, mainly the D penicillamine is used, it is used in copper toxicity, and where in which disease copper toxicity normally happens, it mainly happens in the Wilson's disease. So Wilson's disease is also known as the hepatolenticular degeneration, mainly happens in the children. It happens due to the genetic deficiency of the ceruloplasmin. It is a protein which normally binds and disposes of copper from the body. So ceruloplasmin is a protein normally physiologically present in our body that maintain copper in a normal range. But we are taking copper from myriad sources of the foods. There is always chances of the increased copper, and there is also copper toxicity from the pollutants. In this disease, Wilson's disease, there is genetic deficiency of this ceruloplasmin. That's why copper concentration is increased in the body. So that leads to hepatolenticular degeneration. that is liver as well as the lens, both of these are degenerated. So in the absence of this ceruloplasmin, the plasma concentration of the free copper is very much increased. Ultimately, this increased copper gets deposited in the liver. Apart from the liver, it is also deposited in the substantia nigra in the brain, basal ganglia of the brain, and causes local degeneration of these areas. Lifelong therapy is usually needed to prevent progression of the disease. So Wilson's disease or hepatolenticular degeneration is usually picked up in the childhood cases, and lifelong therapy is needed. Lifelong therapy means lifelong D-penicillamine therapy. So dose is 0.5 to 1 gram daily in divided doses 1 hour before or 2 hours after meals to avoid chelation of dietary metals. So D-penicillamine can be obtained as an oral formulation, and that can be used as a treatment for Wilson's disease or hepatolenticular degeneration. Potassium sulfide 20 to 40 milligram may be given with each meal to decrease the absorption of the dietary copper. So our food, mainly the vegetables, contain high concentration of the copper. In these cases, apart from D-penicillamine, we are using also potassium chloride, potassium sulfide, that can also decrease the absorption of the dietary copper. So it is clear. So penicillamine, mainly the D-penicillamine, because the L form is toxic to our body. D-penicillamine is the drug of choice for copper poisoning. Copper poisoning normally happens in a genetic disease. This genetic disease is known as the Wilson's disease, also known as the hepatolenticular degeneration. In Wilson's disease, the ceruloplasmin concentration is decreased because it is not synthesized. This ceruloplasmin basically maintains the concentration of the copper within the normal physiological range in our body. So in children, when the ceruloplasmin is not there, there will be very high concentration of the copper. This copper gets deposited in the liver, in the lens, in the different areas of the brain, and ultimately degeneration happens. When we are using the D-penicillamine, this D-penicillamine attaches with this excess copper, chelates this, acts as a chelating agent so that the copper concentration is decreased, and ultimately the treatment is usually required for lifelong. So it is clear, treatment of the Wilson's disease. Apart from this, it is also used in direct copper or mercury poisoning, that is acute poisoning of copper or mercury, drug of choice for copper poisoning. Chronic lead poisoning, in some of the cases it is used. The first line drug of the lead poisoning, already we have seen calcium disodium EDTA. It can be used as an adjuvant to calcium disodium EDTA. Cystinuria and cystine stones. So these stones can develop within the kidney. Cystinuria, more cystines are coming out through the urine. That can also happen. It promotes, when the penicillamine is used, it promotes the excretion of the cystine and prevents its precipitation in the urinary tract. This penicillamine cystine complex is more soluble than dicystine. So these are again some types of the genetic disease, cystinuria or cystine stone formation, where also this penicillamine is used. Scleroderma is a connective tissue disease where it also benefits by increasing the soluble collagen. Here the collagen synthesis is deranged. When we are using this, ultimately the collagen, soluble collagen is increased. So penicillamine, where it is used, penicillamine, mainly D-penicillamine is used. The most important indication is the Wilson's disease. Apart from this, if there is acute toxicity of the copper, acute toxicity of the mercury, chronic lead poisoning, cystinuria, cystine stone and scleroderma. So penicillamine is important. Adverse drug reactions, short-term administration usually harmless, does not problem. Various cutaneous reactions can also happen. Long-term produces pronounced toxicity. Usually when in Wilson's disease, it is usually given for long period of time. We have to give some other drugs also to counteract its toxicity. Dermatological, renal, hematological, collagen tissue toxicities can happen. Now coming to the three drugs that are mainly used in iron poisoning, and this free iron poisoning mainly occurs in thalassemia. So you have already read about the thalassemia in your pathology also, some part. So in thalassemia, usually we have to give repeated blood transfusion. When we are giving the repeated blood transfusion, there is always chances of the iron toxicity. Free irons will be deposited in our body. that will be problematic from our body. So for this, 3 drugs are usually used to chelate this excess iron. One is Deferoxamine, next is Deferoxamine, and another is the Deferoxamine. Of this, Deferoxamine is the most important. The first one, it is a long chain iron containing complex obtained from an actinomycetes. So it is usually obtained from a fungus actinomycetes. Chemical removal of iron from it is Deferoxamine. It has very high affinity for iron. You can see 1 gram is capable of chelating 85 milligram of the elemental iron. So 1 gram of Deferoxamine can chelate 85 milligram of the elemental iron. The straight chain molecule, this is a straight chain molecule. When it is given, they forms a round-like structure. Winds round the ferric iron, forms a stable non-toxic component and excreted in urine. So in the hematology chapter, you can remember that we have seen that ferric iron, free ferric iron is quite harmful for our body. Ferrous iron is easier to absorb in our body but not ferric iron. But when this repeated blood transfusion is given, the ferric iron concentration becomes high. When this Deferoxamine is given, they can chelate, 1 gram can chelate 85 milligram of this ferric iron by forming a ring-like structure around this. It removes loosely bound iron as well as that from the hemosiderin and ferritin. Because the hemosiderin and ferritin, which are the storage form of the iron, are become also very high in case of the thalassemia patients when there is repeated blood transfusion. So they can also help to decrease the hemosiderin and ferritin concentration, but not from direct hemoglobin or cytochrome. So they cannot extract iron directly from the hemoglobin or cytochrome. They can extract free ferric iron, they can extract iron from the ferritin as well as the hemosiderin. Little is absorbed after oral administration. When parenterally administered, partly metabolized and rapidly excreted in urine. Again, it is not given orally, it is usually given parenterally. Where it is used mainly in acute iron poisoning, mostly in children. This is the most important indication of the Deferoxamine, which may be life-saving. It may happen that iron is usually used for the treatment of the normal iron deficiency anemia. Many of the mothers of the children who are taking the iron tablets, if they are within the reach of the children, they can take many iron tablets simultaneously. That can lead to acute iron poisoning in children. This is common in our country. So in these cases, we have to use the Deferoxamine in acute iron poisoning. Transfusion siderosis. This is the most common indication, more common than the acute iron poisoning in thalassemia, but the repeated blood transfusion is usually done. Occurs in thalassemia patients who receive repeated blood transfusion. Deferoxamine 0.5 to 1 gram per day intramuscular helps to excrete the chronic iron overload. It may be infused IV concurrently with blood transfusion 2 gram per unit of blood. Usually it is done. So in thalassemia, you can see repeated blood transfusion per month or every fortnight is required. With the blood transfusion in the other hand, usually the Deferoxamine transfusion is given. So simultaneous blood transfusion and Deferoxamine transfusion is given usually in thalassemia patients. Adverse drug reaction, they can cause histamine release, resulting in fall in blood pressure, flushing, itching, urticaria and rashes. Again, the anaphylaxis-like reaction. Variety of allergic reactions can happen, changes in lenses and retina, other side effects, abdominal pain, loose motion, muscle cramps, etc. happen. But if it is needed, the Deferoxamine have to be given. Deferoxamine is the orally active iron chelator. Deferoxamine is a parenterally administered, but this Deferoxamine can be given as a oral tablet. Excessive hemolysis occurs in thalassemia patients. They have to be given after repeated blood transfusion. This is an iron chelator, has to be used to clear the resulting iron overload, what we have discussed. So oral Deferoxamine, usually it is less effective alternative to injectable Deferoxamine, but side effects and cost of treatment are reduced. Deferoxamine, we have seen that this is quite potent. 1 gram can chelate approximately 85 milligram of the iron. This is less effective, but again it can be used orally, so there is no chance, no injections, no transfusion is needed. The cost is also lesser. May also be used for acute iron poisoning, but is less effective than Deferoxamine. facilitates removal of the iron load in hepatic cirrhosis in another indication. So hepatic cirrhosis, in hepatic cirrhosis also there is chances of the iron load. So there will be increased ferritin load. So that can also be decreased when we are using Deferoxamine. Adverse drug reaction and anorexia, vomiting, altered taste, joint pain, etc. etc. Deferoxamine is another iron chelator. This is also oral, the newest one perhaps. It lowers serum ferritin and hepatic iron concentration in patients with chronic iron overload. So when there is serum ferritin is very high, that can happen in thalassemia, that can happen in different types of the cirrhosis, we can use this. Again, non-transfusion dependent thalassemia syndromes. It has high affinity for iron but low affinity for other trace metals like copper and zinc. So mainly this is again used only in case of the iron poisoning. It is well absorbed orally, needs once daily dosing. The Deferoxamine iron complex is excreted in bile. So for iron toxicity, mainly it happens acute iron toxicity or thalassemia patients due to repeated blood transfusion. 3 drugs are given. So Deferoxamine is oral, Deferoxamine is parenterally used, and this Deferoxamine and Deferoxamine, these are oral use, these 3 drugs. Okay. So adverse drug reactions, nausea, epigastric pain, headache, pruritus, rashes, skin discoloration, etc. happen. Details is not required. So more or less similar to the Deferoxamine. Usually the tablet is given in empty stomach. No food is given for next 1 hour. The tablet should be dispersed in water or orange juice before intake because the absorption will be more. Dose to be adjusted later according to the serum ferritin level. Usually serum ferritin level is done every 3 months or 4 months, and accordingly the dose of these oral or parenterally administered iron chelators are adjusted. So you can see in a nutshell, complexing and chelating agents, what are they used in therapy? This is the Dimercaprol, mainly used in acute arsenic poisoning, acute mercury poisoning, and supplementation in lead poisoning in addition to the EDTA. Dimercaprol succinic acid, again it is used in lead poisoning, arsenic poisoning, mercury poisoning. Dimercaprol propane sulfonate, this is another congener of this Dimercaprol. This is used in severe acute arsenic poisoning and severe acute mercury poisoning. So these are the congeners of Dimercaprol, so that the absorption will be more, the adverse drug reactions are less. So that when there is severe acute mercury or arsenic poisoning, usually instead of Dimercaprol or Dimercaprol succinic acid, a newer congener known as the Dimercaprol propane sulfonate, DMPS, is used. This is also used as a drug, DMPS. Okay. Penicillamine, mainly the D-penicillamine, mainly used in copper toxicity, that can happen in Wilson's disease. Adjunctive therapy in gold toxicity, arsenic toxicity, lead poisoning, rheumatoid arthritis. EDTA mainly used in the lead poisoning, both the calcium disodium EDTA as well as the normal EDTA. Deferoxamine, Deferoxamine, these are mainly used in acute iron poisoning as well as the iron overload. Again, this is an important, this is in a nutshell, you can see calcium disodium EDTA. So when you are asked what is the main indication of the calcium disodium EDTA, that is the lead poisoning. So lead poisoning, it is the intravenous or intramuscular administration is done, not effective for the chronic lead poisoning. Usually acute lead poisoning it is given, it is nephrotoxic. All of these chelating agents are also toxic to the organs. That is the problem. IV administration can increase the intracranial pressure. So lead encephalopathy, cerebral edema can increase. Zinc supplementation may be beneficial because they can chelate normal zinc that is required in our body also. Dimercaprol, also already we have seen. What is the main indication of Dimercaprol? Acute arsenic poisoning, acute lead poisoning, acute mercury poisoning, etc. It is mainly administered intramuscularly, not effective for chronic intoxication, increases toxicity of the iron, cadmium and also selenium. So it is contraindicated here. Toxicity profile is worse than for Succimer. Succimer is the newer one, lesser adverse drug reaction, more or less similar, mainly used when the blood lead concentration is very high, greater than 45. Lead poisoning, off-label for adults with lead poisoning and for arsenic and mercury poisoning, it is also used. The same thing, I am telling this repeatedly so that it will be easier to understand. It is orally bioavailable, improved toxicity toxicity profile over Dimercaprol, reduce mobilization of the lead to brain, may cause allergic reaction. Copper chelator, already you have seen the penicillamine, the D-penicillamine, and another thing is the trientine. This is lesser used nowadays. Penicillamine already we have seen, mainly used in the Wilson's disease. Treatment of the copper intoxication due to Wilson's disease. Chelates heavy metals, more toxic, less potent, less selective. It is orally bioavailable, allergenic, nephrotoxic, cause hematological reaction, etc. Trientine is another one that can be used as a supplementation in Wilson's disease. It is orally bioavailable, but it is less potent than penicillamine. That's why it is lesser used. But this is the another drug that can be used in copper poisoning as well as the Wilson's disease. So penicillamine, trientine, these are the copper chelators. Heavy metal chelators, most of the heavy metal chelators is the calcium disodium EDTA, Dimercaprol, and different congeners of the Dimercaprol like Succimer. And iron chelators, there are 3 iron chelators already we have discussed. Deferoxamine used. All these, the indication is the similar, both the acute iron toxicity as well as the thalassemia, where the repeated blood transfusion causes transfusion siderosis, increased ferritin level, increased iron overload. Usually intravascular, IM or subcutaneous administration done from Deferoxamine. Subcutaneous administration is preferred for chronic iron overload. Intravascular used for cardiovascular collapse or shock. Intramuscular administration for other acute iron intoxication. So when there is acute iron intoxication, there are different types of the symptoms, and accordingly there are different areas by which the routes are usually chosen. Details is not required. Deferoxamine and Deferoxamine, these are orally used. Again, the indications of the same. Orally these are used, but the effectivity is less, but the cost is lesser. That's why it is used, as well as the infusion is usually not required. But the problems are always with all these chelating agents. Most of these are nephrotoxic. So renal failure, hepatic failure, gastrointestinal hemorrhage can happen in all of these. All of these are allergenic as well as anaphylaxis, anaphylactoid reactions can happen. So not causes agranulocytosis, neutropenia, this Deferoxamine. Neutropenia means neutrophil count can decrease, so increased chances of the infection can happen. So this is in nutshell about the chelating agents. So within the chelating agent can come as a short note in your examination. Individual chelating agents, most commonly Dimercaprol, penicillamine, or the iron chelators or EDTA. These 4 can come as a short note in your examination. And in the Viva also, usually it is asked, what is the indication of this Dimercaprol? What is the contraindication of Dimercaprol? What is the main drug that is used for the copper poisoning in Wilson's disease? What is the main drug that is used for lead poisoning? These are the very commonly used questions that can also come as your MCQ. So this is all about the chelating agents.